My pleasure. Thank you, Rio. And thank you for everyone for attending. It looks like we have about 35 people in the room. So thank you for logging in to hang out with us for a little bit. Just a couple points and things to share up front. I do have online with us Paul Rosenberger from the National Registry Office. So he's going to be kind of hanging out, but if we have any specific questions specific for the registry, we actually have the voice of registry with us today, which is really, really cool. So thank you, Paul, for joining us today. And also just kind of for everybody, this is the first in a series of webinars. There's a bunch of change stuff that we're going to introduce today, but there's a lot more information to come. So on the NAEMSE website, there's a schedule of events, and you can actually start registering for some of the webinars. But there's a webinar every month or every other month that talks about more in detail what I'm going to introduce today, the changes, the processes, some best practice stuff, some suggestions for classroom work and evaluation work. So today is going to function really as an intro to kind of whet your palate to what's coming. Also, there are 3 seminars, face-to-face seminars, 8-hour seminars that you are open to attend as well. We have one coming up in Texas, Dallas, Fort Worth on February 23rd. And I believe the registration is open for that now. So that'd be a great face-to-face and interact with some of your peers from across the country. We have another one that's taking place in May of 24, May 17th, 2024 in Chicago. And then we will do a final one in Pittsburgh at the NREMT symposium in August 15th of 2024. So there will be all the webinars that will run down through here. You can join all of them. They will all be recorded. You can share them with your staff, your faculty, with your deans, with whoever you wish. And then if you're up for a little jaunt either to Dallas or to Chicago or Pittsburgh, sign up and join us for a face-to-face. That would be great. This program was put together in combination with NEMC and the registry in a partnership to collaborate and kind of help us make sure that we're all on the right page, getting our students what they need. There's a series of 4 of us that were working on this. Art Saya, Jeff Anderson, and Bill Young. We're all part of the team that built this, and they will be the 4 presenters that will be presenting over the next year. And they will be the presenters. The 4 of us would be together at the 4 face-to-face, actually 3 face-to-face. We did one at NEMC a couple months ago, which I think went really well. I think the audience was pleased. So all of that information to preface why the change and what's changing. And I guess by starting, we should probably ask and identify what is changing and what's taking place. And I think many times people, when we talk about this, they don't even know there is a change taking place. But there's a fair amount of stuff changing. The big thing that people talk about change here when they talk about the registry is they say that the psychomotor exam is going away. And yes, the psychomotor exam is being sunset. But that's one component of the change. There's changes in structure, changes in test formatting, changes in evaluation process, changes in COA requirements. There's a variety of changes that are transpiring over the next year or so. And so again, this is just going to introduce what those changes are and give us some information about what we can do and how we can move forward with them. And if we look at it, the process that we have now has been in place for quite some time, and it's served its purpose. But I think we're at a point we can do better. I think we can do more with the stuff. As said at the beginning, if you have questions as we go through, feel free to put them in the chat or in the Q&A. Rio's monitoring the question and answer for me, and then I'm kind of monitoring the chat. If it's specific to what we're talking about now, I think it's relevant to answer the questions and address them as we go forward. If it's something we can wrap up at the end, we'll kind of wait and then just do a big question and answer at the end. And then loop in Paul if there's anything he wants to add from the registry standpoint. So The National Registry, this is their mission statement. So from back in 1970, it's been centered on protecting the public and advancing the EMS profession. And I think that last line is very, very important, advancing the EMS profession. Part of advancing means that we just can't stay stagnant. We can't keep doing what we've always done, because it's that definition of insanity. If you keep doing what you've always done and keep getting what you always get and expect to change, it's not going to happen. So as we, the emergency medical services, specifically at the ALS level, the AEMT and the paramedic level, are kind of growing and maturing, and all kinds of discussions about a variety of things related to this education, including degrees and practice and everything else. It's time for a change. And so I think these changes are going to do a good job of protecting the public as identified and advancing the EMS profession and creating more critical thinking practitioners. I think is kind of the goal of this whole process. So we have current status. So we know that this is BLS, and none of the stuff we're going to talk about today directly affects the BLS, the EMT, or the EMR exams at the registry level. But that being said, I don't think there's any reason why, as program directors, lead instructors, that some of this stuff can't be incorporated into your EMT classes and into your EMR classes, because it's just going to prepare them to be better practitioners, and it's going to prepare them for their advanced level classes if they choose to move to AEMT or paramedic. But basically, the state approves the program, the EMT program. The program is run by the program as accredited by the state. And then the program jumps on National Registry's website, and they click that the student has completed the program, and they click that the students have verified the skills. Programs have the ability, based on their individual state guidelines, to put them through whatever skill attestation they wish. Many states use a scenario-based exam. Many programs use a scenario-based exam. Others use a step-by-step skills checklist, and you shouldn't do that anymore. Move to a scenario-based exam. But then you go to registry, and you just click off that they're competent on these skills. Then the student can go sit for the National Registry written exam and obtain their National Registry certification. At the ALS level, it's a little bit different. So we have a state-recognized program, and currently, the majority of the states require COA as an accreditation process for paramedic programs. For those who don't know, I'm totally on the side. The COA is in the process is allowing for AEMT certification or accreditation process. So if you run an AEMT program, especially if you run a paramedic program, it might be a good piggyback to put the AEMT under accreditation with your paramedic program. But they go through an accredited paramedic program. COA looks and guides and offers input as far as how the program is supposed to be run. The program verifies the content and verifies on the National Registry website that the student has successfully completed all components of the program. And then the National Registry comes in, and the National Registry verifies the skills. So the National Registry comes in and does what used to be the 12-step exam, and then we moved into more critical thinking type components of the exam, where we're doing the out-of-hospital scenario and the oral exams and the mega code stations, and all the skills currently in the National Registry ALS test have to do with some form of critical thinking piece that takes place. Moving forward, in 2019, the National Registry did their practice analysis. And in the practice analysis, it was identified at the ALS level that paramedics and AEMTs use clinical judgment, leadership, and communication skills to perform their job roles. This piece of information was so impactful, and that it triggered National Registry to actually create another domain of testing and evaluation on the National Registry exam. So they actually added a level, or in the process of adding a level, that's going to actually evaluate clinical judgment, leadership, and communication skills to perform their roles. That then was one of the first components of what registry identified as the ALS redesign. This QR code up here will take you the same place that the link at the bottom of this picture will take you. So if you've not been here yet, if you go to the National Registry website, the National Registry website has a link, and it's called the ALS redesign. And the ALS redesign will take you to the National Registry's page that talks about what's happening, and it gives you a timeline, and it lays it out as far as what's happening and where we are. So far right now, we've made it past milestone number 1 at the top, the initial design phase. Number 2, the practice analysis, and we just saw some of the output of the practice analysis, specifically identifying that ALS providers need to focus on leadership and communication and critical thinking and clinical judgment pieces. And then we're starting the process of developing new content. So registry right now is in the process of writing new items. So if you have not heard it, if you have not participated, and I'm sure many of you have participated, you can reach out to registry, because registry is always looking for question creators and question reviewers and content reviewers to help make sure that we that the questions that are being asked are valid and good, and we're actually asking what they want to do. And that's happening right now. There's been several meetings, both face-to-face and virtual, where registry has gathered our peers from across the country, and they've written questions and they've evaluated questions and they've looked at different items. And many of these items are actually currently being piloted on the AEMT and the paramedic test. So some of your students at the AEMT and the paramedic level may come back and actually tell you that they're actually seeing some of these items because they're in the pilot phase to take place. You can see the loop around the wheel, and registry does a nice job, and I don't have a picture of it here, but they've done a nice job of color coding the star of life as they complete tasks. The task I'd like to focus on right now is this milestone number 7 right here, with the sunset of the psychomotor exam. So coming mid next year, the psychomotor exam will no longer be available. Our students will not take the psychomotor exam, which from an accreditation standpoint and a certification standpoint, that's a huge piece to be removed, because that piece, in concert with what the program verifies as far as skills, that psychomotor exam becomes kind of the outside evaluation of critical thinking and skills as appropriate for the paramedics. It has its flaws. There's some subjectivity to it. There's a variety of difficulties, including the implementation of it. But it's done a good job for years in doing what we need it to do. But next year, it goes away. So at some point in time, we have to figure out, we as educators have to figure out how we're going to evaluate this critical thinking piece in addition to the skill piece thing that takes place. So if you run a paramedic program, you are probably familiar with this document, the Student Minimum Competency Summary Tracking Form. If you're not familiar with this document, whether you're with a paramedic program or a EMT program or even an EMT program, I would go to the COA's website and take a look at this document and just see how it lays out. And what it does is it tells us how many patients we're supposed to see, how many patients we're supposed to see, of what age, of what gender, of what complaints. It identifies what we're supposed to do as skills, what we're supposed to do as far as evaluations, and it sets the minimum level of what's supposed to take place within the program. This new document was implemented effective 1st of this year, and all currently accredited programs must be using this document. And they will submit the summary sheet to allow the students to be able to sit for the registry test. So knowing that registry is moving through the change and that registry is getting rid of the skill component piece, this SMC document plays a role in helping us verify that the students are getting the contacts that they need, that they're getting the patient types that they need, that they're getting the skills that they need. And this will substitute the actual skills assessment that was done by registry at the end. So the programs will do the skill assessment. The program will do the summary assessment, and they'll document that in this SMC document, which can then be presented to registry to let you know that the students are competent to take place. So we have upped and changed a little bit what COA is requiring of us. We have removed the psychomotor exam, or going to remove the psychomotor exam. It's still here, don't write it off yet. But next year, mid next year, the psychomotor exam is going to go away. And so we as a profession have lost a little bit of the critical thinking piece. So the minimum competency document does a good job of documenting skills, contacts, patient types, all those things. And just on the side, you as a program director can set those numbers. You can set those numbers. So COA has a variety of recommended numbers, but you, with your medical director, in concert with your advisory committee, have the ability to set those numbers higher or lower, as long as your advisory committee approves, your medical director approves, and it's justifiable to the COA. So we document the numbers, the types, and the patients and the skills that everyone is seeing. So we come around back to the how are we going to evaluate the critical thinking piece, or the clinical judgment piece. And so basically, we need a new test. We need a new test that evaluates critical thinking, clinical judgments, troubleshooting, because the registry written test now, I think, does an okay job of that. But I think there's some room for it to grow and do better. I think our test within our program, we have the ability to grow and do better. Plus, registry's added that whole additional domain about communication and leadership and clinical judgment, which is going to be a new level that's being tested at the registry. It's never been tested before, at least not directly been tested before. But now it's going to function as its own separate independent domain. With that, there's this document, proposed theoretical framework for clinical judgment in EMS. You see authors written down below. And what this group of experts did is they looked at what is clinical judgment in the pre-hospital setting. And they identified kind of what it is, and they identified what it's not. So for example, critical thinking is a component of clinical judgment. It's not the same thing as clinical judgment. And so they put together a framework as far as what this is and how this looks. And I think we will make sure, I'm not sure how we could do it, but make sure everyone knows how to get this, or has a link to it, or can access it on some point in time. It's posted multiple places. It's a open access document. But this document is being used as the framework to set and build this new National Registry exam, which in future webinars, we'll talk about how we need to take this same document and build our educational program and our content, and how we need to rewrite our own exams within a program to make sure that our students are going to be prepared for what we're doing based off of this document. Within the document, the thing I'm going to show you is this, because it's pretty, and it has colors, and it has pictures that are going to take place. And so what it does is you can see everything across, but to depict it, we start up at the top, and we have the dispatch information, we have en route, we have on the scene, and then we have the post scene. And so this clinical judgment identifies that it's not just one piece of the puzzle. So students have the ability, or should be able to do some clinical judgment to make some decisions while they're going to the call. Students should have some clinical thinking and make some decisions when they're on the call. And then post scene. So whether the post scene is we're refusing, whether the post scene is we are transporting, the student should have some clinical thinking piece. If you look at through the line, there's a leadership line and a communication line. And leadership and communication are threaded all the way through this process. And so when we look at it, we have to evaluate how are we going to evaluate this? What are we going to do? The students have to be able to demonstrate leadership ability, decision-making ability, and communication skills. So if you look at the three circles the three circles, which are, thank you, Paul. Paul in the chat has posted the article on clinical judgment. So the three circles identify the three areas: en route, on scene, and post scene. And if you look at the breakdown, it gives us kind of a loop around for what students are expected to do. Underscored by that bottom line down there, patient cues, environmental cues, and provider factors. And so, for example, en route, it talks about recognizing the clues. And so when a student is dispatched or when a provider is dispatched on a call, we make some decisions. We know about the neighborhood we're going to. We know about the weather that we're driving through. We know about the hospitals that are available to us. We know about the other resources that are available to us. And then we get the information about the actual call. We follow the loop around, then before we get on scene, we analyze. What did we hear? Come up with some type of hypothesis about this is what I think is going on. So even if it's as simple as I know that intersection and it's a high-speed intersection and traffic accidents tend to be pretty bad, that would be forming a hypothesis as we're driving to a call, and then generate some type of solution. So maybe it is I'm going to need help with extrication. I'm going to need help with traffic control. I need aeromedical support for transport. I don't know. It depends on the scene. And then we float around and we want to take action. We want to take action. So we actually call for a heavy rescue team. We actually call for a helicopter, which then means we need to call for someone to land the helicopter. So we need to follow this up, and then we evaluate what's taking place. And so it's a cycle of stuff that takes place en route. For a seasoned provider, I think we just do that. We get in the ambulance, we get dispatched, and all of that stuff just kind of runs through our head. But we need to make sure that when a student is graduating a program, an advanced level program, that they can actually demonstrate that they can do that. That they can demonstrate, they can use that thought process to facilitate their clinical judgment. So when they arrive on the scene, they're more prepared to take care of the patient. They arrive on scene, it's the same thing. They start with the recognition of cues. Simple things like, what did they see in the house? Do they see oxygen tanks? Do they see walking assistant devices? Is there other healthcare providers on scene? Are there alcohol bottles strewn across the house? What do they see when they walk into the house? And then they need to have the process of analyzing the cues. And this analyzing, defining hypothesis, generating solutions thing, that loop right there has to do with a lot about teaching people how to think. So thinking about thinking, or commonly referred to as metacognition. And that's what we're doing with these students now, is we need to help them develop and work on some type of process of metacognition. Which future webinars, that's what we're going to focus on, is this process of how do I do that in the classroom. What's happening here is registry is going to recraft the exam, and so they're evaluating the student's ability to do metacognition. And so when it comes to being on scene, the ability to recognize the cues that are on scene, what people are saying, what they see, what they hear, what they smell, to be able to analyze those cues and then put them together in some type of hypothesis. And we tend to be in EMS, and I know folks have heard me say this before, but we tend to be very Pavlovian about things we say and we hear. And so we hear things like that. Patient presents with the chest pain described as rib tear stab. Everyone goes to an immediate hypothesis. All of a sudden, someone's short of breath with pinpoint non-specific chest pain, and we go right to a specific hypothesis. So we have these little buzzwords and these little keywords that we use in EMS, which I think has been good early on, and it makes a nice linear thought process. But through this process, especially if you're working in the field, you know that on scene is not that clear. It is not that distinct. And so we have to help students identify the cues. What do they see? What do they hear? What do they know? And then what do they think is happening? And based on what they think is happening, they need to come up with some type of solution, a proposal of treatment, a proposal of action, a proposal of reassessment, a proposal of what do I do next, whatever. And then they need to do something. They need to do something. They need to evaluate what they did. and then they need to recognize the cues and then follow the circle all the way around. It's a normal treatment plan. A lot of this doesn't sound unique or bizarre, or I'm sure, because it's largely what we do. And I would guess many of us in the throes of teaching our paramedic students and our EMT students, and even some of our EMT students, will say that we do this. What we need to make sure is happening is that this is actually being evaluated. So currently, this is evaluated through the out-of-hospital scenario. So when paramedics and EMTs, actually I think the EMTs do it, when paramedics do the out-of-hospital scenario, this is what they're given. They're given a dispatch call, and then they walk in, and they have to recognize the cues, analyze cues, put together a treatment plan. You have to roll out a treatment. You have a professional partner there helping it take place. And then we have the oral station A and oral station B, where students then talk through this process. They talk through the process of going en route and being on scene and all of this stuff. And with the psychomotor exam being sunset, the National Registry needs another way to evaluate this thinking process. And with the assistance of the document and this tool right here, we have a matrix and a format which we can actually use it to teach, but then we can actually build a template to test how students are thinking and what they're doing. And arguably, I think it probably does a better, more objective job of evaluating students' ability to think and put together treatment plans and recognize cues than the out-of-hospital scenario might do. And then we move into the post-scene, and commonly the post-scene is going to be while we transport. And so it's the same thing. You get the patient in the back of the ambulance and you recognize the patient cues. Does the patient get better? Does the patient get worse? Does the patient develop a new complaint? Does the patient go unconscious? Does the patient start seizing? Analyze those cues, put together a hypothesis, come up with a solution, and then take action. So all of a sudden, an unconscious patient who fell off a scaffolding starts seizing or something. They should recognize that, and then they should come up with a reason why. Why do you think the patient's seizing? Come up with a solution. I think I should stop the seizure, and then take action. Probably the administration of some type of benzodiazepine, and then evaluation process. Reevaluate, has the seizure stopped, and then continue around with the recognition of cues going, I just administered a benzo. I wonder if the patient's going to quit breathing, and then continue this loop around. So it's this continual thought process that takes place. As you can see, underscored by the ability to take a lead, to make decisions, to judge and direct people appropriately, and then to communicate. How are you going to communicate? Who are you going to communicate to? What's that communication going to look like? And again, I think we probably do a good job putting this together in our classes. And most people would probably look and say, yeah, this is what all my scenarios. This is what my scenarios look like. This is how I run my scenarios. They get dispatched, they run, they get post-call, patient changes, they reevaluate. Awesome. We can work on this in the classroom. Group discussions, tabletop scenario type things we can talk about. We're going to talk about later in the webinar series about how you get your preceptors on board with this, because that's going to be the huge piece. That's where your goal is with your preceptors, because they're actually out there doing this. They're doing this thing. So we need to make sure that the preceptors are on board with helping our students think about what they're thinking about and helping them think about why they're making a decision. Because when they get to the registry test, the registry is going to test this. They're going to test this process about how do we think and what are we going to do, because we need this replacement of the psychomotor exam. And even if we can run a whole bunch of scenarios in our programs, and we can do a great job simulating stuff, but to some degree it becomes simulated. And then when we run calls in the field, we never know what the student's going to get in the field. We know there's this kind of weird dichotomy that the really high call volume systems tend to run lower acuity patients, and the lower call volumes tend to run higher acuity. So you get students get higher acuity, but they have low volume, and so we've got to find this match of where we go with volume. And there's a very good chance that the students will get into a routine of just running calls, and they just run a whole bunch of great calls. But this piece is missed. And so on the registry is going to evaluate this whole process. Please keep in mind that this is a whole separate domain added by the registry. It's a whole new group of things. Leadership, communication, and clinical judgment is a whole new group that's going to be tested and evaluated, in addition to all the other medical pieces and everything else that takes place with this. All right, good. Questions or anything thus far? I don't see anything. All right, great. And so the new registry test. This is kind of what the new registry test is going to look like. There's going to be scenario-based items in the registry test. So when you go to the test, you're going to have a series of multiple guess questions like you always do. So A, B, C, D, pick the best. Here's your patient. What do you do next? Here's your signs and symptoms. What do you think it could be? Normal questions. But within the exam, there are going to be scenarios, and the scenarios are going to be broken down into 3 separate sections, just like we saw the loop-to-loop things from the report, from the document. And so what will happen is there'll be a scenario that's given, and the students will read the scenario. And the scenario, they will ask 3 to 4 questions about the dispatch information. And the questions will be things like, what do you want? What are your concerns? Where are you going to go? What do you want to bring in? Who else do you want to be on scene? A series of questions about that dispatch information. After the students go through that process, it then shifts, and the students will be on scene. And when you see the test, and I'm going to help you with that in a minute. When you see the test is actually going to show you the scenario off to the side, and the scenario off to the side will stay there, and the students will get a series of questions. And then when they arrive on scene, the scenario shifts to being on scene, and then you get 3 or 4 questions. The students can always go backwards to the dispatch information, but they can't go forward to post-scene information, and they can't go backwards with their questions. So they can't get on scene, go backwards, and change their mind about what they wanted to do with the dispatch information. They have to keep moving forward, but they can always go back and access the information that they actually received during dispatch. So then there'll be 3 or 4 questions about on scene, and it's the same questions that focus on patient care. What do you want to do? What do you think it is? What's the difference between this and this? And we'll talk about some of those question types in just a minute. But there's going to be 3 or 4 questions about the scene. After the students answer those, the scenario moves forward, and we're going to get 3 or 4 questions about post-scene. And so the post-scene is going to ask what's a primary focus of reassessment. The patient now presents like this. Why do you think they're doing that? Changes that take place. And so there'll be 3 or 4 questions about the post-scene event. And so it's going to run students through an entire scenario. The scenario will all come together. So you're going to get pre-scene, on-scene, and post-scene. It'll all come together. The questions within the scenario might vary. So if you have a whole class of 10 people, they all may get the same scenario, but there's a very good chance when they get the dispatch questions, they won't be the same dispatch questions. And when they get the on-scene questions, they may not be the exact same on-scene questions. So there's some randomization that exists in there. And the exam tends not to so in other words, how you answer one question does not predict how you get the next question. It's randomized. So it's not adaptive like other components of the exam are. The other component is what is referred to as TEIs, technology enhanced items. And this is what I think is really, really cool. What we want students to be able to do is we want students to be able to differentiate this from that. On the out-of-hospital oral stations for the practical exam, that last phase, that last little box in the oral station basically says it's your assessment of what's taking place. And that's your opportunity to speak to your evaluator about what do you think it is, what do you think is going on. Maybe we come up with a diagnosis kind of thing, and have that conversation back and forth with the evaluator. That's going away. And so we need to have the ability for the students to demonstrate that they can actually think that way. So these technology enhanced items, In addition to the pick A, B, C, D, there's going to be matching items. And so with matching items, you might see questions like, based on this scenario, patients maybe having, I don't know, shortness of breath and chest pain, something. And so the question might be, from the list below, select the items that or the physical findings and assessments that are associated with myocardial infarction, as compared to thoracic aortic dissection. And so there'll be a list of findings, and students will have to pick and choose which of those findings, physical findings, go with MI or thoracic dissection. So it demonstrates this critical thinking, which is a component of clinical judgment. There are sequencing questions. And so for years, we've been this IVO2 monitor transport, which I hate that polysyllabic word. And Mona hopefully is gone. She just needs to go away. We won't use Mona in some while. But what this question, and Mona's not even in order. It's not even in the correct order. So there's actually sequencing questions that take place. So you have a patient and they'll say, here's your patient, you have the scenario over here. From the list below, put the treatments in the appropriate order. And so they're going to ask students now to prioritize, what do they want to do first? What do they want to do second? What do they want to do third? What do they want to do fourth? So things have to be put in some type of sequence. And these groups that registry has put together to evaluate these test questions, which they draw from providers from across the country, that's what they do. They sit in a room and they discuss about the sequencing and the matching. Is this the right order? Is this the right sequence? And some amazing discussions take place around that to come up with the best. This is what we think the best order is or the best sequence is. There are multiple select questions. And with multiple select questions, instead of saying pick A, B, C, or D, it will say something like, of the list below, pick the 4 findings that are associated with this condition. And there'll be a list of 7 items. And of the 7 items, the student will have to pick the 4 that are associated with this item, or the 2 that are associated with the presentation, or whatever it may be. So they're going to have to pick and choose which are associated with this, or what treatment they should pick, whatever the case may be. And then the grouping of putting things together, which is kind of similar to a matching thing, slight variant about putting things together based on how it presents. And so this new testing process is put in place to evaluate the student's ability to critically think and put together some type of clinical judgment when it comes to patient care, patient assessment, patient transport, which is necessary because the registry psychomotor exam is going away. We're not going to have a megacode assessment station anymore. We're not going to go through 4 separate rhythms anymore. We're not going to have 4 static strips anymore. We're not going to sit through 2 oral exams anymore. We're not going to sit through the out-of-hospital scenario anymore. And all of those scenario-based assessments were designed, as we said before, to evaluate this critical thinking, this patient care piece. And a lot of it, if you remember the old national registry test, it was all skill-based. Walk into the room, stick a plastic arm, walk into the room, intubate a plastic head. It was very, very skills-based. The most current registry psychomotor exam is more about critical thinking and clinical judgment than it is actually skill-based things. And so we will take, as a program, the responsibility of verifying and attesting to skills and all the skills that they need to do and all the skills that they need to take place. And then the registry has the new exam to evaluate their clinical judgment, their leadership, their communication skills, and that whole other additional domain. At the same time, they're evaluating the medical questions as well. Because within these scenarios, even though there are questions that are focusing on communication, leadership, and clinical judgment, you can't ask those questions without asking some type of medical question to take place. So it's kind of putting the whole thing together. I put that QR code back up there again. That QR code will take you to the ALS redesign page. And the ALS redesign page, there's tons of information. It tells you how registry is changing, what's taking place, why it's changing, why the new change. And then the coolest thing on that page is at the top right of the page, the ALS redesign page, there's a link. And it says something like, experience the new exam. And so you can click on that page And when you click on that link, it actually takes you to, I believe it's an AEMT level test, but it actually takes you to a new exam, and you have the opportunity to go through that exam. Registry wants people there. They want people on that website. They want instructors looking at the new exam. Send your students to the new exam. Send them there and have them take the exam just to see what it's gonna feel like. From a program director standpoint, we should start creating some of these questions. And many of our online learning platforms, our digital platforms we offer tests, have the ability to do this. I specifically work with D2L at my institution, and I can do almost all of this stuff through D2L, including the scenario creation, and have the students walk through the scenario. So, but we'll talk about that in other webinars. Again, kind of wet and whistle for really, really cool stuff. The other thing on the ALS redesign page, if you scroll all the way down to the bottom, there's a series of webinars that are down there. Some's talking about the implementation, the new process. And I think it's the most recent, but Paul actually does a webinar talking specifically about this test, about what it's going to look like, and talks about the specific technology enhanced items or the TEIs, and gives more information about that. All right. Great. So not tons of in-depth information, because we have other webinars coming up that are going to fill our hearts and minds with information. So Paul, is there anything I missed or anything you want to add?
No, Dennis, I think you did a great job there. The only thing I'm going to add is we're having our own webinar tomorrow, and I'm going to put the registration into the chat. So if you wanted to attend that, that would be from 1 o'clock to 2 o'clock Eastern time tomorrow. But other than that, I'm just sit back and answer any questions that may pop up that are related to me.
And again, I encourage, I've had the opportunity to work with COA and NEMC and registry for a bunch of years. And as things change, there's been many times I run into situations where we'll be at a conference, like the NEMC conference, and people are just shocked that something has changed, that something is new. So share this information, send it out, send it to your faculty, send it to your preceptors, send it to everybody, and get to where, so we can work collaboratively as educational institutions to prepare students to be able to take these tests. And the resources they have found, registry has a variety of webinars that are taking place. NEMC has a series of webinars that are taking place. Ria, I don't have in front of me, what's our next webinar? Do you have that right in front of you?
Yeah, let me check that for you real quick here.
And I think registration for that is open, if I'm not mistaken.
Yep, that is correct. It looks like it's October 25th on deciding what to teach.
Okay, perfect. And the remaining webinars, what we try to do is we completely understand that we can't get the entire United States EMS education population to 4 separate face-to-face sessions. So what we did is, the full faculty, we kind of took the webinars or the content of the 8-hour day, broke them into 8 little sections, and we're going to present each little section as we go forward. And so information about how do you implement this into your classroom? How do you facilitate this metacognition, or this thinking about thinking process into your classroom, into your lab? How do you get your preceptors involved to help them foster this clinical judgment and critical thinking piece? Are all going to be the future webinars that are taking place. And then on the registry side, registry is actually showing you the test. They're showing you exactly what it's going to look like. So you can take the test, you can take it over and over and over, and again, send it out to your faculty, send it out to your students, let them take the test, just so they have an experience about what it's going to look like. All right. Does anybody have any questions out there? It's like we're up to about 50 of you now. Do they have any questions or comments? And I think Jeff and Bill, I think you're on the call too. So if you have anything you want to add. All right. So Rio looks like they're all good and all knowing, or I bore them to tears, one of the two. So thank you everybody for hanging out with us this morning, and follow up with the links on the registry site and the NEMC site, because there's good resources coming from both of those places to help you move forward. As I said, this is just an introduction to kind of what is changing and why it is changing. Awesome. Thank you, everybody.
Awesome. Thank you so much, Dennis, and thank you, Paul. Everyone, I dropped some links in the chat up there for you, but no worries if you miss those, because I will make sure all of the links included today will go in tomorrow's follow-up email, as well as a recording of this webinar, okay? And we will see you all next time, all right? So thank you so much, and have a great day, everyone.
Hey, Rio, Sherry
sorry.
said that the link did not stay or send us to anything but the live event that hasn't started.
Oh, for Paul's link, maybe?
Yeah,
I don't know.
I think that is intended for me. I would tell you to put a placeholder on your calendar for tomorrow at 1 o'clock Eastern, and then click on that link, I guess 10-15 minutes beforehand, and that should take you into the session.
Cool. Thank you,
Perfect.
Paul.
Yeah, and it's saying that the link hasn't, or the event hasn't started, but it doesn't start till about 24 hours from now. Probably 23 hours.
Awesome. Sherry says yes. Awesome. All right. Thank you again, everybody. Have a great day.
Thank you. Bye.